Our session today, as you know, is on multiple gestations, and my talk is really going to be an introductory talk, talking a little bit about the epidemiology of multiple gestations, the embryology, and then leading into the complications that the other speakers will speak about. I have no conflicts of interest to report. And as I said, I'm going to start talking about epidemiology and then talk about embryology, because I think it's important to go back to the basics to kind of review that. I know we've all been through it before, but for me at least it's been a while, and it was fun to go back and look at the illustrations. We'll also spend a little bit of time talking about monozygotic versus monochorionic, because while we all basically understand it, I think it's good just to make it clear, because there are differences between the two, and occasionally they get used interchangeably, and they're really not. So we'll spend a little bit of time talking about that. And then at the end of the talk, we'll start going into what we do and the ultrasound piece of it, and a lead into some of the complications with chorionicity. We'll talk about the diagnosis of chorionicity, how the various parameters that we use perform in terms of making that diagnosis. So I'll present some data looking at that, and also talk about why we have some issues with that diagnosis sometimes. So let's start out looking at some overall U.S. birth statistics. And these are from the CDC, from the National Center for Health Statistics. And this is 2011 data. And you can see that multiple births are about 3.5% of births in the United States. And that's risen from about 1.8% in 1971. And I'm going to show you some more graphs and things to show you that increase. We're going to talk about why it's increased and go through that in detail. Also, 20% of multiple births are conceived by IVF. So that was an interesting number just to look at. And I think we're all aware of the contribution of IVF to multiple births. Also, 36% of twins are secondary to fertility treatment, and 77% of triplets are secondary to fertility treatment. Now, note that I've used fertility treatment instead of IVF here. So we're going to talk about that distinction, because as you'll see, there's a difference between whether the multiples are due to IVF or to other fertility treatments. And there's some relatively new data that breaks that out, which I think is really interesting in terms of the causation of multiple gestations. Here is a chart, again, from the National Center for Health Statistics, looking at the incidence of twins in the United States from 1980 to 2009. And you can see the top blue curve looks at the incidence, and the numbers on the right are 35 per 1,000 births. Now let me just point out, remember I said before in that earlier slide, the incidence is about 3.5%. More typically, and we'll use this numbers throughout most of the talk, those numbers statistics are reported out as number per 1,000 births. So that would be 35. So that's, you can see up here that 35 is right there. And you can see the rise from 1980, and I think that's a nice graphical way just to be able to see that. It hasn't been uniform across the states, which is interesting. If you look at the increase, again, from 1980 to 2009, you can see the percent increase varies by region and state, where you can see that while the total U.S. increase in the time period was about 76%, it varies from less than 50% to 100% or greater. And you can see the 100% or greater are these little states right along here. And why that is, hard to know. Is it the water? Who knows? But there are geographic differences for whatever reasons, not well understood at this point. Another factor which is really important when you look at the rate of twinning is maternal age. And here is a graph from that same set of data looking at incidence by maternal age. And you can see the blue is in 1980 and the green is 2009. And here's under 20, and you can see the rates per thousand. And you can see as maternal age goes up, the incidence of twins goes up. And you can see how dramatically that has changed in the 2009 data. Look at the difference here up until an incidence of 40 and over of about 71 per thousand in 2009. So it's important to remember that maternal age is an important factor in terms of twinning. Now, it's important for another reason too, because when you look at data and statistics, you have to adjust for maternal age to be able to have a good comparison. So when I show you some other data, you'll see adjustments for maternal age, and that's the reason is this data here looking at the difference in incidence in maternal age. Another thing, and it's part of the data, but it's also not so easy to see, and this slide shows it pretty well. If you look at the percentage of births between 1980 and 2009 that are over the age of 30, you can see that that has increased dramatically. So just because of that, that will increase the incidence of twinning because the increased number of women of advancing age who are having babies. So again, another important reason that we need to adjust the statistics that we look at for maternal age. Here is a set of graphs, and it's from an article published by Kulkarni in the New England Journal at the end of last year. And it's a very interesting look at the etiology of multiple births in the United States. She's from the CDC, and what she looked at, you can see in the top panel on the upper left, is the observed and maternal age-related adjusted weights of twin births. And we're going to look at these age-adjusted ones for the reasons that we talked about before. But you can see that same curve that you saw before pretty much from the National Center of Health Statistics. This is data from 1971 to 2011. And you can see the gradual increase in twin gestations. That increase to 2009 was about, once it was age adjusted, is about 1.6 times increase in the incidence. The data from 2009 to 2011 is pretty flat and may even go down a little bit, and I'll show you that in a minute. If you look at the incidence of triplets and above, you can see that here is this increase again up until about 1998, and that increase was about 4.8 times increase. And then from 2008 on, there's been about a 30% decrease in the incidence of triplets, which is interesting, and we'll talk in a couple of minutes for some of the reasons for that. Here, if you look at the age distribution of twins, you can see that back in 1971, about 75% were in women that were less than 30, and that has gradually dropped, where women in the mid-30s and over 30s has gone up. And you can see a similar curve looking at the drop in younger women and the increasing rate in older women over that age period. Now, what are some of the reasons for that? And if you look at it, and this is really the meat of the paper, and what they looked at is method of conception. And one of the important things is that what they did was, instead of just looking at IVF, they tried to look at other fertility treatments. And remember, I showed you those statistics at the beginning. And the way they did it was, which was interesting, first of all, this graph starts at 1997 instead of 1991, because 1997 was the first year that IVF statistics were reported from SART, the Society of Reproductive, I don't know exactly what the acronym is, but they're the IVF people, started reporting their statistics. Now, unfortunately, there isn't any national reporting for other fertility treatments. So what these investigators did was took as a baseline the rates of multiple births from 1962 to 1966, before any ovulation or assisted reproduction was being done, used that as a baseline. So that was the way they were able to tease out the difference between IVF, assisted pregnancies, and other reproductive technologies. And if you look on this top curve, you can see that the natural conceptions for twins has dropped a little bit, and the red is the medically assisted, where the non-IVF treatments are the purple and the IVF is the green. So you can see that for twins, for non-IVF has gone down a little bit, and the IVF has gone a little bit. Now, if you look at multiples, triplets and above, you can see that the natural ones are way down here, the blue now, and they're almost all medically assisted, no surprise. But here's the difference. Look at the IVF rate. The IVF rate has dropped here in triplets and above from IVF. And what's gone up slightly is the other IVF treatment. So this was really one of the main points of the paper, is that the increase in multiples, especially above twins, hasn't been due to IVF, but it's been due to other assisted reproductive technologies. So that's important to remember in terms of looking at where these come from. And here's another curve looking at just the contribution of IVF towards multiple gestations. And you can see singletons in the top, twins, and triplets. And you can see that the singleton rates are actually going up, where twins are going down a little bit, and triplets are going way down. And actually, 2005 was the tipping point where less than 50% of pregnancies from IVF were not multiples. So there's been a huge change in the contribution of IVF to multiple pregnancies. And here's probably one of the biggest reasons for it, is looking at the number of embryo transfers. This is 3 or more, and you can see how that's dropped dramatically. This is double, 2, and single embryo transfers are starting to go up. They're still not a huge percentage of the number of transfers, but they definitely are going up. And you can see down at the bottom, for elective single transfers, meaning that there were other embryos available, but they chose to just transfer one, is going up dramatically. So while the overall number is still relatively low, that is changing. And why is it changing? Well, a couple of things. First of all, SART, here's the acronym, Society for Assisted Reproductive Technology, first came out with their first guidelines. They've had a number of guidelines which have come out, but the first ones were 1998, when you saw the start of the drop, but their guidelines were to reduce the number of embryos transferred. Also, the effects of insurance coverage probably have had some impact on the number of multiples. As insurance has started covering more and more assisted reproduction, there's less of a push from couples to feel like they have their one shot at it and need to transfer 7 or 8 or whatever, like in the old days. Public reporting and just making people more aware of it have probably had some impact, and also improvements in pre-implantation screening and IVF, going to blastocyst transfers, which have higher pregnancy rates, and the full chromosome screening also has improved the pregnancy rate. So I think that the IVF centers have felt more comfortable with single embryo or 2 embryo transfers. So I'm hoping that is a trend that'll continue. Now, what are the risk factors for multiple gestations? We talked about the biggest one a lot, assisted reproduction. There also are ethnic differences, which we'll talk about. We've talked about maternal age. I'll show you a little bit more data with that. Family history is also a factor for, especially for non-identical or dizygotic twins. it's one that's hard to quantify. There's not a huge amount of data, but there is some data suggesting that in a first-degree relatives, if there are a number of multiples, the chance of multiples does go up. But it's very hard to sort out for the literature, and I'm not going to present any of that data. Here is, again, looking at some of the ethnic data, and you can see that the twin birth rate doubled among non-Hispanic white mothers over the period, and this is again from 1980 to 2009. And you can see the differences, though, between Hispanic, and this is the 2009 data, non-Hispanic blacks, non-Hispanic white, and this is all races. So there are significant differences in ethnic background in terms of twinning rates, which most of you are aware of. Another interesting look, and this is the incidence of twins in developing countries where there isn't really much of a contribution from assisted reproductive technology. But you can see the differences with the highest rate in mid-Africa here to much lower rates in South America, in Asia, but it's interesting how dramatic those numbers are in terms of the differences in twinning. And I'll give you a couple of numbers of the range of that in just a minute. An interesting study, and this is very, very old data from California, but I thought very interesting. If you look at, and look right here at these two numbers, right here, the incidence of twinning in Japan, and this was a number of years ago, and this number was reported from Japanese living in Japan of about 5.8 per thousand. But the California data, which is, as you know, a multi-ethnic state, looking at Japanese, the incidence was almost double of twins. So there clearly are some factors in terms of environment and other things that go into changing those numbers. So I thought that was interesting looking at that. And there's consistent among other ethnic groups also. Okay. So those are the factors for looking at twins, a little bit about the epidemiology and numbers and what's happening with those rates. Let's talk a little bit now about monozygotic versus monochorionic. And monozygotic is derived from, the definition is derived from a single fertilized egg, typically called identical, and they can be monochorionic, as you know, or dichorionic. Monochorionic developing from a single chorion. The incidence of monozygotic twinning is constant across cultures. It's about 4 per thousand. It's not changed. It's the same in different ethnic groups. What does change is the incidence of dizygotic twinning, and you saw that graph in the developing countries, and you can see here that one of the highest rates is in Nigeria of about 40 per 1,000. To much lower, one of the lowest rates in Japan of 6.7 per thousand. How are they formed? Most of you, as I said, have seen this embryology diagram in your training, but the traditional thinking is that the type of twinning that you get depends when the cleavage takes place. So if cleavage happens very early on day 1 to 3, you get a dichorionic, diamniotic pregnancy. If it happens on day 4 to 8, the blastocyst stage, now remember this is important, so I'm going to come back to this. Remember, this is when most or many IVF transfers are happening now at the blastocyst stage, so remember that. Most of those are going to be monochorionic, diamniotic. Later at cleavage day 8 to 13, we'll get monochorionic, monoamniotic, and at day 13 to 15, we end up with conjoined twins. Now, what's the contribution of each of those types? If you look at the dizygotic twins, the diamniotic, dichorionic, that is about 72% of all twins. Monochorionics, monozygotic, the diamniotic monochorionic, which is the most common, is 20% of all twins, with the dichorionic, diamniotic, dichorionic, 8%, and the rarest of all, the monos, less than 1% of all twins. Okay, here's the first question. Are fetuses with monochorionic placentas always monozygotic? True or false? Okay. The answer is mostly true, not completely true. There are a few cases that have been reported where that isn't true, where that looks like they're dizygotic, and whether that's due to chimerism or other issues early on, or a loss of the chorion in between. It's very unclear what the etiology is, but if your patients come back and say they looked it up online and they're not all that way, tell them that it's just a couple of cases. So essentially that is a true statement. So that is something that you generally can tell people, but as you know, they'll look it up and they'll come back and ask you. Okay. So let's look at those placentas and how we make that diagnosis and what they look like. And this is a couple of histology views looking at the placentas from dichorionic and monochorionic. And here you can see the placental dividing membrane coming off of the placenta right here. And on this dichorionic one, you can see the chorion going up between the two layers of the amnion. So pretty clear, and that's an enlargement of that area, seeing the chorion. Where here you see is the dividing membrane coming off here from the placenta, and you don't see the chorion coming up in between the two layers. So that's histologically how it looks. How does that translate into how it looks ultrasonographically? Well, people have looked at a variety of ways of trying to make the diagnosis of chorionicity. There were initial reports of trying to look at the layers in the membrane, and that is really tough. I know, if any of you have tried to do that, that's very, very difficult in early gestation, and it depends on the angle of insonation and the size of the mother, all kinds of factors, and so that has been very difficult, and most people, I would say, are not using that. Then people looked at the thickness of the inner twin membrane, and again, that's very subjective. There are no clear criteria that people use. Many people have suggested greater than 2 millimeters, but there really is no standard in terms of looking at that, so that is not that widely used. What is used and tends to be used most widely is the lambda or twin peak sign. Those are really interchangeable looking, and I'll show you examples of that, but most of you clearly know that. Or the T sign for a monochorionic, and again, I'll show you signs of that. Also, seeing separate placental masses is helpful for knowing if they're dichorionic. And just to remind you that the diagnosis of chorionicity is included in all of the societal guidelines for first trimester scanning. So it should be done on every multiple gestation. Here is a set of diagrams from an article by Juan in 2011, a prenatal diagnosis. And here you can see the two chorionic sacs. Here you can see the lambda sign or the twin peak sign with the chorion going in between, and this is enlarged a little bit. And much harder to see here, which is harder to see on ultrasound also, is the T sign and the very thin membrane. I'm not really going to say much about monoamniotic, monochorionic, except one of the things you look for are the cords coming off next to each other and actually intertwined between one another. So that's ultrasonographically how the diagnosis is made. How about this one, looking at this? Is this monochorionic or dichorionic? Okay, I heard some monos, I heard some dis. This picture is a 16-week scan from this one, the same pregnancy. So, goes to show you how things can change at 16 weeks. And I'll give you some data now looking at sensitivities and specificities of the diagnosis, but clearly an illustration of how much more difficult it can be as you get towards mid-gestation. And here's one of the reasons why we think it happens. Here you can see this dark area here is the chorion coming up in between the amnion. And if you scanned right here through that layer, you'd see a twin peak sign. You'd see chorion. This is a dichorionic placenta. If you scanned here, there's no chorion, and you would call that a monochorionic. So that's the reason, looking at the gross pathologic specimens, probably why that difference in inaccuracy exists. One study, and this is a fairly recent study in ultrasound and obstetrics and gynecology in 2011. It's the largest series looking at this. There have been a number of other series that support it. Looking at 11 to 14 week scan patients, and these were patients coming in for the nuchal translucency, multiple gestations. They looked at lambda sign and T sign and placental masses, and the confirmatory test was placental histology or discordant sex at birth. And what they found was, looking at less than 14 weeks, that the sensitivity was 100% and the specificity 99.8%, so very high. This is another study, a little older one from 1995, looking at diagnosis of chorionicity. The mean gestational age of this study was 23 weeks. And you can see how the sensitivity drops when you get further along. Sensitivity is only 92%, specificity 97.3%, and sensitivity for dichorionic is 97.3%. And by 20 weeks, about 7% of dichorionic placenta will not have a twin peak sign. And that, again, depends on that regression of the chorion that you saw on that histologic specimen. Another thing that the WAN study looked at was the accuracy of referral diagnosis. These were investigators from UCSD, and they looked at what the referral diagnosis was when the patient came into them. And look at the differences. This was from 2003 to 2009, just to give you a time frame for it. If the referral diagnosis was dichorionic, if the actual diagnosis was diamniotic dichorionic, the referral diagnosis was right about 45% of the time. They were right 98% of the time. Diamniotic monochorionic, a little better, 48% versus 96%, and monoamniotic monochorionic, 50% and 83%. Looking at in triplets, it was even worse with the referral correct diagnosis of 28% and a triamniotic dichorionic of 24%, so not nearly as good. What was really surprising to me was that if you look at the number of cases that were referred in with no mention of chorionicity on the ultrasound report, twins, 46% of cases that they received had no diagnosis on the referring report that came in, and triplets, 64%. So even though it has been part of guidelines for a long time, it still is not being routinely done. Now, you know, it's a little bit old, and it's probably improved somewhat, but I think it's important for all of us to remember that and to encourage our colleagues to do this if they're doing ultrasound. Okay, let's look at another quick question. A 28-year-old G2P1 with a spontaneously conceived twin pregnancy died by early sono. 16-week sono reveals 2 males. The patient asked, "Are my babies identical?" Here's the answer. It's not that intuitive necessarily. I gave you the numbers in terms of how the distribution was, but the answer is here. It comes from a pretty old study by Cameron looking at placentas from 1998. And what he did was looked at the placentas, and the ones that ended up being same-sex and dichorionic, he did genetic studies. Now, genetic studies at that time were just looking at enzyme differences in blood types. They didn't really have DNA studies back then. So, you know, we probably could get a little more accuracy, but Interestingly, what he found was of the same-sex dichorionic, the situation that I presented, about 8% of the 45% were monozygotic, so that's close to about a 20% incidence. So that's the right number to tell patients when they ask that. And we all get that question a lot. Okay, one final thing. Let's talk about twins in assisted reproduction. As you know, most are going to be dizygotic, but there is an increase in monozygotic twinning that we all know about and have seen with IVF and other assisted reproduction. And about 1.5% to 2% of all clinical pregnancies after ovulation induction are monozygotic. And there's a 4 times increase compared to spontaneously conceived monozygotic pregnancies. Now, as you know, most that we see are monochorionic diamniotic. And we would expect that by remembering back to that embryology slide as to the timing of when the cleavage happens. But let me just point out to you that there are a number of reports now in the literature that report dichorionic, diamniotic, monozygotic twins following ovulation induction. So it can occur. Now, sometimes you always wonder, did they transfer 2 instead of 1? Was there a spontaneous conception at the same time as the IVF? That's much less likely. That doesn't happen very often. So this is a real phenomenon. Why it happens biologically, this would mean that it would be a later cleavage at the time of blastocyst, but we're still seeing a diamniotic, dichorionic twin gestation. So just to let you know, no one understands the biology for sure yet, but it can happen, so don't be surprised when you see that. Hopefully I've given you a little bit of an introduction into the twinning process, how we make the diagnosis, and the next talk we'll talk about how we manage twins and manage some of the complications. Thank you very much.
So I'm going to focus more now on the complications specifically of monochorionic pregnancies. I have no financial disclosures. My objectives, I want to discuss the mortality and morbidity of monochorionicity and specifically discuss diagnosis and management of more of the ultrasound complications or the fetal complications, including twin-twin transfusion syndrome, selective intrauterine growth restriction, twin anemia polycythemia sequence, and twin reversed arterial perfusion sequence. Of course, monochorionic twins also have high risk for preterm labor, preeclampsia, diabetes, but I'm going to focus more on the fetuses. So as Jim mentioned, monozygotic twins, splitting of a single fertilized egg for about 30% of twin gestations, with a constant rate of about 4 in 1,000 across all populations, almost always genetically identical, and 70% of them are typically monochorionic. Again, the images of the splitting of the when it happens, as it happens later, closer together, the placenta's fused. And I just like this comic. It also emphasizes what Jim was saying, is that I think they're identical twins, but I'm not sure. And as we'll see, it's really important to identify the chorionicity always at the beginning when you see these patients because of the complications that arise. So chorionicity rather than zygosity is the main factor determining pregnancy outcome. And genetic disorders and chromosomal abnormalities are typically also dependent on the chorionicity. So the rate of miscarriage and perinatal death is much higher in monochorionic twins than dichorionic twins. And the death of a monochorionic fetus also has that potential effect on its co-twin with the sudden death of the co-twin or severe neurological impairment. So complications. Here is a study that was published in 1997 that shows monochorionic versus dichorionic twins, and you can see as you get further on in gestation, very early on, monochorionicity is much more dangerous than dichorionic twins. And then in this study, they actually broke it down between dichorionic and monochorionic twins that were uncomplicated. So not the ones that had twin-twin or SIUGR, the ones that were being managed completely with no complications. There's still a higher risk for loss versus dichorionic, and you can see a pretty big drop right here at about 36 to 37 weeks. So with the single demise, as I mentioned, you have these anastomoses in the monochorionic placenta. So when you've got one demise of the twin, the other one can also be affected by hypotension or emboli that travel through. They're more likely to miscarry before 24 weeks, about 6 times more likely than dichorionic twins. There's about 3 times higher risk for perinatal mortality versus dichorionic twins, and they're more likely to have cerebral palsy, about 8 times more likely versus dichorionic twins. So the first question for you in the audience is, what percentage of monochorionic diamniotic twin gestations are at risk for twin-twin transfusion syndrome? You have A, 0 to 5%, B, 10 to 15%, C, 25 to 30%, or D, 40 to 50%. So yes, the 2 respondents were right. It is B, 10 to 15%, 100% accuracy here. So let's talk about twin-twin transfusion syndrome. Typically, it presents at less than 26 weeks and about 90% perinatal mortality if it remains untreated. Monoimmunicity is thought to be protective, but has about a 6% incidence of twin-twin. So why does twin-twin happen about 10 to 15% of the time? Well, there's this net transfer of blood from the one fetus, called the donor, to the other fetus, called the recipient, via these vascular communications. And typically, there's these arterial, veno-venous that are superficial bidirectional flow, but there are these arteriovenous connections that can be deeper and unidirectional flow that are really problematic. So here you can see a pathological specimen along with the cartoon next to it. Up on top, you've got the normal bidirectional flow that is not problematic, whereas the one below shows that abnormal vascular connection with the unidirectional flow. And just another cartoon illustrating when you've got a donor and a recipient, these unidirectional flow of the anastomoses that causes problems. So you can actually map it out on ultrasound if you're able to find these vessels. You can move from one Doppler that shows the arterial portion with pulsations and onto the venous connection where you've got the continuous monophasic signal. So the second question is, which of the following is a sonographic predictor of twin-twin transfusion syndrome? A, CRL or crown rump length discordance, B, nuchal translucency greater than 95%, C, velamentous placental cord insertion, D, 20% estimated fetal weight discordance, or E, all of the above. Okay, so we've got 6 people responding, about half saying D, and I guess the other half saying E. And the answer is E. It's all of the above. All of these are predictors that may be concerning for potential development of twin-twin. In the first trimester, if you've got a significance difference between crown rump lengths, if you see a nuchal translucency that's greater than the 95th percentile in one twin, or if there's a greater than 20% discordance between the twins, or if you see reversal or absence of the ductus venosus A wave. In the second trimester, you can sometimes see abdominal circumference discordance, membrane folding, velamentous placental cord insertion. That puts you at higher risk for developing twin-twin, placental echogenicity, where the donor portion appears hyperechoic, and 20% estimated fetal weight discordance. Twins in general have a higher risk for about 6 to 9 times of having a velamentous placental cord insertion. So here you've got an ultrasound image of the increased NT that was seen in one twin as a potential predictor. The velamentous cord insertion, both the pathologic specimen and the ultrasound, where you can see the donor was the one with the velamentous cord insertion. The folding membrane, that's showing that there's a reduction of fluid around the donor twin. So once you have the suspicions, you're going to start staging them. We're all very familiar with the Quintero staging. You've got stage 1 with oligohydramnios and polyhydramnios of at least less than 2 centimeters and greater than 8 centimeters MVPs, respectively. Going into stage 2, where you've got the fluid volume discordance and no bladder in the donor twin. Stage 3, where you start to see Doppler abnormalities. Stage 4, where you have hydrops in one or both of the fetuses. And stage 5, where you've lost at least one or both. So this is a video where one of our patients that we had with developing twin, where you can see a kind of stuck twin up on top, and the bottom one has much more fluid and no bladder in this donor twin. So other images of the different stages, stage 2 here on the left, where you don't see the bladder anymore. Stage 3, where you're starting to see absent and diastolic flow in the umbilical artery. And stage 4, where now you're starting to see fetal ascites consistent with hydrops. Also with the ductus venosus, reversal of the A wave can also be a sign of stage 3. So once you're starting to become suspicious and you've confirmed poly, discordant bladder sizes, typically we recommend a Doppler panel for staging, and that includes the umbilical artery SD ratio, the middle cerebral artery peak systolic velocity, the umbilical vein, looking for pulsations, and the ductus venosus, looking for presence or reverse flow. Stage 1, expectant management is typically recommended with weekly check for fetal bladders, the maximum vertical pocket, and doing the Doppler panel every week, with delivery at 34 to 36 and 7 weeks gestation, although individualized. So what about stage 2 and higher? Well, typically laser photocoagulation is recommended, and I can't believe somebody actually made a cartoon about it, but I thought this was really funny with the recipient being very scared. So with the laser ablation versus amnioreduction, there's clear benefit for the laser. 2 studies showed that laser ablation decreases the risk for dual death, overall death, perinatal death, neonatal death, and higher likelihood of having neurologically intact infants at 6 months. And these were all statistically significant. As you can imagine, the higher stage you go, laser photocoagulation results decrease, and so both survivors typically decrease as you go into the higher stages, and with at least one survivor is hovering around 80%. So this was a video that was made at our institution to look at how laser photocoagulation works. And so first it starts with these 2 monochorionic twins that look fairly similar, and then you've got the decreasing fluid around the donor twin, which leads to that stuck twin, and the increasing bladder and the polyhydramnios around the recipient twin. And you can see as the membrane moved over, the vessels that are needed to be visualized for laser photocoagulation are more clearly seen. So now you can start to see these anastomoses that you typically can't see if you don't have poly-oly. Then you've got this laser that goes in and finds the connections that are concerning for likely unidirectional flow, and they're burned on both sides for each one of these anastomoses. And that's why it's, once you've decided you have twin and you're going to intervene or send them somewhere for intervention, you want to avoid doing something like an amnioreduction or a septostomy, because this procedure really relies on being able to clearly see the equatorial plane where there's the difference between the polyhydramnios and oligohydramnios to be able to identify the vessels. So once the vessels are identified and the laser is used to occlude them, then what happens is, in order to kind of make this division for any smaller vascular anastomoses, the laser is just connected through all of these anastomoses, and that's called the Solomon technique. So for stage 2, 3, and 4, it's recommended that laser therapy be offered between 16 to 25 and 6-7 weeks gestation. If they're unable to do laser therapy or outside the gestational age range, consider amnioreduction. And then again, considering delivery at 34 to 36 and 6-7 weeks gestation, although again, individualized to each case. Stage 5, now when you've already lost one twin, there's a risk about 10% for the co-twin death and a 10 to 30% risk of neurological problems. But unfortunately, delivery is not going to improve the outcome for that remaining twin, and so expectant management is recommended with, again, the similar delivery recommendations. So moving on to selective intrauterine growth restriction, similarly to twin-twin, it affects about 10 to 15% of monochorionic twins, where you have one twin with normal growth and typically normal amniotic fluid, and the second twin with fetal growth restriction less than the 10th percentile, and sometimes oligohydramnios. You can see a pretty large estimated fetal weight discordance, and that's why it can be difficult to sometimes differentiate between twin-twin and SIUGR because they can present very similarly. When you've got early SIUGR, the presence of the anastomoses are actually beneficial to that smaller twin. They can get the oxygenated blood from its co-twin as a rescue transfusion phenomenon, and about 5% of SIUGR cases occur later during the third trimester. And the placental architecture for late SIUGR versus early IUGR is typically very different. So they do have stages for SIUGR that are not as prevalent as the Conturo staging for twin-twin, but there's type 1 where you have normal Dopplers, typically benign course, low risk for IUFD or co-twin neurological damage, and usually you can typically get to more than 34 weeks. Type 2, you've got consistent absent and reversed and diastolic flow in your umbilical arteries. There's a high risk for IUFD in that small twin. There's a low risk for actually causing some kind of neurological damage, and mean gestational age at delivery is about 29 weeks. Type 3, this is where you have actually intermittent absent or reversed and diastolic flow. There's a low risk for deterioration of that twin, but there is still this 10 to 15% risk for sudden, unexpected death in the small twin, or 10 to 15% risk of neurological damage in the co-twin without a demise. So here's a sonographic image of one of our patients who developed SIUGR very early on in the late second trimester, and trying to show, although it's hard to get the exact same cut between both twins in the same image, that A has a much larger circumference than B. And then Doppler differences between the both. The IUGR twin had consistent absent and diastolic flow, and the normal sized twin had normal diastolic flow throughout the umbilical artery. The MVPs tend to be fairly similar, or they're slightly decreased, but it typically doesn't go into the extremes of the oligohydramnios, polyhydramnios that we look for in twin-twin transfusion syndrome. So that patient ended up getting delivered early on, I think around 32 weeks, and the small baby was about a little over 400 grams, and unfortunately demised in the perinatal period. So the other one's doing well. So the third question, which of the ones below have not been shown to improve prognosis for selective intrauterine growth restriction? A, observation, B, selective reduction, C, laser ablation of the placental anastomoses, D, bipolar coagulation of the IUGR baby's cord. So the answer is actually laser ablation of placental anastomoses actually hasn't been shown to really change any of the outcomes. And the study that I'm going to show you next is where it was looked at in about 2008, where they compared observation to laser treatment and showed that the IUGR twin really outcomes didn't improve with laser, and both twins actually did better if you just observed them and delivered based on worsening Dopplers. So for IUGR, we typically recommend first diagnosing with an estimated fetal weight less than 10% in one fetus and discordance of greater than 25%. Do the Doppler panels that we also do for twin-twin with the umbilical artery SD ratio, the middle cerebral artery systolic velocity, umbilical vein pulsations, and ductus venosus diastolic flow, and then consider cord occlusion of the smaller twin or laser therapy, more if you're just concerned that an IUFD is about to occur and delivery is not recommended. We do weekly ultrasounds with MVP fetal bladders and ultrasound Doppler panel. We repeat the biometries every 3 weeks, start weekly antenatal testing as early as 28 weeks, and delivery by 34 to 35 weeks gestation if the Dopplers remain stable. Of course, earlier delivery depending on if there's going to be a potential concern for an IUFD in the smaller twin. So now we're going to move on to twin anemia polycythemia sequence, also known as TAPS. This is the last question. TAPS is most likely due to A, spontaneous development, B, viral infection, C, status post laser ablation for twin-twin transfusion syndrome, or D, alloimmunization. So it's actually due to, the majority of the time, it's due to post-laser ablation for twin-twin. So the TAPS placentas have only a few AV anastomoses, so they kind of allow for the slow transfusion from the donor to the recipient. So you typically don't see the oligohydramnios, polyhydramnios that you see with twin-twin. Now for spontaneous TAPS, it's about 3 to 5%, but post-laser increases to about 8 to 13%. So the Doppler ultrasound abnormalities that we look for in TAPS is the middle cerebral artery peak systolic velocity, where in the donor twin it increases, suggestive of anemia, and decreases in the recipient's twin, suggestive of polycythemia. And the typical recommendation is donor greater than 1.5 MOMs and recipient less than 0.8 MOMs. But again, there's stages, just like there were for SIUGR. Stage 1 and stage 2 typically have no fetal compromise. The Dopplers are discrepant, as noted on the slide, but otherwise the rest of the fetuses are doing well. Stage 3, you start to see other cardiac compromise where you have absent or reverse and diastolic flow in the umbilical arteries, pulsatile flow in the umbilical vein, or reverse flow in the DV. Stage 4, you've got high drops, and stage 5, you've had an IUFD of one or both twins preceded by TAPS. So this was a patient of ours who had laser treatment. Initially the Dopplers before she had laser photocoagulation for stage 3 twin-twin were pretty similar with their peak systolic velocities. And then 4 weeks post, there started to be a significant discrepancy between the two, and then a little bit later, even more discrepancy and requiring early delivery. So with TAPS, the outcome is really the need for blood transfusion or partial exchange transfusion was in this study was shown to be significantly different in TAPS versus other monochorionic twins that served as the controls, whereas the cerebral injury, neonatal death, or neonatal morbidity was about the same. So management options really dependent on the gestational age. You can do expectant management, delivery, you can try a transfusion, a selective feticide, or the repeat fetoscopic laser surgery. But like I said, it's a lot harder once the fluid has normalized between the two twins. And that's why that Solomon technique that you guys saw in that video that I showed, where you kind of connect the dots, is really important, because for TAPS, there are very few small, almost microanastomoses that can lead to it. And so trying to make sure you eliminate that whole plane is important. There's spontaneous resolution has been reported, and mostly the perinatal morbidity and mortality is based on small case series or case reports. So how do we manage our monochorionics if they just come in? First trimester, we obviously want to confirm their chorionicity, establish their gestational age or confirm it, check for the crown rump length discrepancy, look at the nuchal translucencies and detection for any major anomalies. After that, starting about 14 to 16 weeks, we have them come back every 2 weeks to look at the maximum vertical pocket in each sac, the fetal bladders. At 16 weeks, we add in biometries, and we do them every 4 weeks. At 20 weeks, we're doing a comprehensive anatomy ultrasound, again, biometries. This time we do Dopplers and look at umbilical artery Dopplers and MCA Dopplers at this one visit, and then baseline fetal echocardiograms for both those fetuses. Continue on Q2 week monitoring. We don't do Dopplers unless there's a sign for concern. We start weekly antenatal testing at 32 weeks, and we do MCA peak systolic velocity Dopplers at 28 weeks, 32 weeks, and 36 weeks to monitor for TAPS. With delivery, typically in the uncomplicated monochorionic twin, we recommend between 36 and 6-7 weeks gestation, although NICHD says 34 to 37 individualized on situation. So this is how we also manage our patients, where we're trying to see, okay, are they going into one of the complications? So if we start to see oligohydramnios and polyhydramnios, where you've got the MVP greater than 8 and the less than 2 in the donor, with the bladders being discrepant, we start thinking more of a twin-twin and start managing them that way. If we don't see that, but we really see discrepant weights between the two, then we start thinking of more of an SIUGR management paradigm. And then if we don't see that and we see the MCAs are pretty discrepant between the two, we start looking at it as more of a TAPS diagnosis. Finally, if we've got some of this but not all of it, we just monitor them very closely to see if they develop into one of these. So finally, I'm just going to talk a little bit about twin reversed arterial perfusion sequence, which is another complication of monochorionic twins. This is also known as the acardiac twin, and it occurs about 1% of monochorionic pregnancies, or 1 in 35,000, so very rare. There is a high risk for anomaly in that co-twin. That's the, quote, normal twin, about 10%. And the perinatal morbidity and mortality for losing the normal twin is upwards of 50%. You can have polyhydramnios or cardiac decompensation in the pump twin. And we really talk about this as a tumor when we talk about it to our patients. So here you can see some images of ultrasound images where you've got a normal twin and then this very just mass that appears. This is a video of a patient we saw where you can see some anatomy, but really it just looks very, very abnormal, and there's no cardiac activity specifically in that twin. So these result because of the same kind of anastomoses for development of that acardiac twin, and like I mentioned, we typically refer to it as a mass or tumor. It's dependent on the co-twin for its hemodynamics. If you let it grow and don't intervene, it can lead to congestive heart failure in your normal co-twin, fetal demise, polyhydramnios, which would of course subsequently potentially lead to PPROM, preterm labor and delivery, and very high risk for mortality for that pump twin of upwards of 50%. So recommendation for fetal cord ligation in order to eliminate that connection between the two. Once you do that, the survival of the pump twin increases to about 70 to 80%. And radiofrequency ablation has actually been shown in some studies to have a lower prematurity rate of 23% versus 58% of the other methods. In other methods, like here we show bipolar forceps, you go in and you find the umbilical cord close to the mass, and you occlude it in order to avoid any further movement of the blood into that fetus. So in summary, determination of chorionicity early on is critical in the management of these twins. Monochorionic twins are a much higher risk for complications and require closer surveillance. Ultrasound imaging is critical for distinguishing between twin-twin transfusion syndrome, selective intrauterine growth restriction, and twin anemia polycythemia sequence. And the management is dependent on the severity of the disease. Thank you.
Talking about invasive procedures in multiple gestations. I'm going to do the questions a little bit differently. The way that mine are sort of embedded into the talk, the answers really don't follow right after in the discussion. I'll go through the questions and the answers and let you guys answer, and then we'll pull it up as we get to the sort of that point in the talk. Both Joanne and I have no financial disclosures and no conflicts of interest to disclose. So the outline, basically what we're going to do this afternoon is talk a little bit about some of the prenatal diagnostic procedures, looking at both CVS and amniocentesis, and focusing on the fact that there's actually not much data with respect to these procedures. And then turning to multifetal pregnancy reduction and selective termination in both dichorionic twins and monochorionic twins. So as been mentioned in our first two talks, twin births do account for upwards of 96% of multiple births. The percentage is around a little over 3% in the United States. And we do see sort of the incidence of higher order multiples has increased up to about 4%. And there are multiple causes that come into this, as have been mentioned, assisted reproductive technologies, ovulation induction, as well as maternal age. And also has been mentioned, and as many of us know, these pregnancies are at increased risk for different adverse outcomes, maternal outcomes, just to name a few: hypertension, diabetes, postpartum hemorrhage, and fetal adverse outcomes. We're going to focus a little bit on the genetic and structural abnormalities, growth restriction, preterm delivery. So what are the reasons that we talk to women or we offer women invasive prenatal diagnosis? So in monozygotic twins, as has been stated in our previous two talks, they are almost always identical. So the risk in each fetus is related to the singleton age-related risk, although there can be some post-splitting abnormalities that are seen. In dizygotic twins, each twin themselves have an independent risk, so approximately 2 times her age-related risk. And assisted reproductive technology in ICSI is associated with an increased risk of aneuploidy, specifically sex chromosomes, autosomes, imprinting defects. Some of this may actually be related to some of the reasons why these women had to pursue fertility treatment. Other reasons, so the non-invasive prenatal screening or the free fetal DNA is really not ready for prime time in multiples, although there are some labs that are offering it, and it still is a screening test at this time. Some women come to us just for levels of anxiety, whether it's things they've read, things that they've had in previous pregnancy, family members and friends, or some just purely based on choice. We both work in the Upper East Side of New York City, and you can imagine there's a lot of women that come to us just already planning on what, with their CVS already scheduled. Abnormal screening testing, structural abnormalities may lead women to pursue testing. And as we're going to talk about, women who are interested in fetal reduction or selective termination. So what are the incidence of chromosome abnormalities in at least one fetus in a multi-fetal gestation? And if you look in the column on the left, just looking at the maternal age in increments of 5, and how that changes based on the number of fetuses that she has. So in a 20-year-old, her risk in a singleton is 1 in 526. To twins, that increases to 1 in 263, similar to as if she was 34. For triplets, 1 in 175, similar to that of a 36-year-old. And if you go down to, say, a 35-year-old, who's often a woman who's referred to for genetic counseling and testing, singleton 1 in 192, with triplets up to 1 in 64. In 2004, Brambati looked at what was the incidence in patients who were undergoing CVS prior to multi-fetal pregnancy reduction, comparing that to women undergoing the procedure for singleton pregnancy. The incidence of chromosome abnormalities per pregnancy in his study was around a little over 7%, and more than half of them actually occurred in women who were under 35. So again, sort of getting away from that 35-year-old as being the person that it's offered to. When we looked at our data in patients who were specifically undergoing fetal reduction, and we looked at, there were increments, 2 separate studies that were done looking at increments of the first 1,000 compared to the second 1,000. In those second 1,000 patients undergoing reduction, 9% of patients or of pregnancies had a chromosome abnormality. Just a small sort of breakdown here, 30% of those were mosaic, 13% sex chromosome abnormalities, and 21% autosomal. And 3.5% of all fetuses in this group had abnormalities. So, I will come to amniocentesis as well. But when we want to talk about what is the loss rate in women who are wishing to pursue invasive prenatal testing, there really isn't a lot of data. And oftentimes when there's not a lot of data, we want to look to sort of our governing bodies to sort of give us some guidance as to what we should do or how we should counsel the patients. But there really is sort of a little bit of a discrepancy because of that lack of data. So if you look, the Royal College's statement is the loss rate after CVS and amnio is likely to be higher in a multiple as compared with a singleton. Just likely. ACOG mentions invasive testing, but there's really no comment on the risk of adverse outcomes. The Society of Obstetrician and Gynecologists in Canada say the risk of pregnancy loss in twins before 24 to 28 weeks is somewhere between 1% to 4% following an amniocentesis, although we know the risk for some of these patients of loss is around 5%, regardless of procedure. And in Australia and New Zealand, their college doesn't even quote any figures on the issue. So really not a clear consensus on what the risk is for these patients. So first, to just surely because of timing in the pregnancy, CVS and multiples, there's some technical issues that are associated with it. We do have about a 99% success rate, but there is about a 1% risk of cross-contamination. And you can see in that picture up on the right how it may not be easy depending on the number of fetuses that you have. And proper mapping in these cases is very important. Particularly, even if patients are not coming to you with the thought that she's going to want to undergo a reduction, but if we're talking about that at least, say, 3% of the fetuses in the patients that we saw that had a reduction have an abnormality, it would be important to make sure that you know which fetus was the one that you sampled. And we do find sometimes people that refer to us to undergo the procedure, if they've had CVS or something beforehand, without that map, we're unable to ensure which fetus is in fact the one that was abnormal. And sometimes that means that the procedure has to be repeated. So just the pictures on the bottom, the one on the left is just showing a transcervical with the arrow pointing to where the catheter is, and the picture on the right is a transabdominal. So this is just a picture, one of the pictures that we use of the mapping, labeling each fetus and where the placentas are. We want to describe the locations as best we can, where the placentas were located, lowermost, anterior, right lateral, left lateral. Just the more information that you write on there, the better. We not only scan that into the chart, but we give the patient a copy to have to bring back with her just in case. So when you look at the risks of CVS in twins, there really are no randomized controlled studies, but there are 9 studies, and 2 of which had controls. And the overall loss rate quoted in this review is about 3.5%, with a loss rate under 20 weeks at 2.8%. Now, the 2 studies that actually did have a control group, in the first by ATAS, the overall loss rate in those who underwent the procedure was 2.7%. Those who did not, 3.2%. In DeCat, the overall loss rate, a little bit high, but 7.4%, but compared to their controls was 8.4%. So again, we're putting this against the sort of natural background risk of twins. So neither study showed a significant difference in the loss rate, and that's in the 2 that actually had controls. For amniocentesis, sorry, I don't have as pretty of a picture. Most of us use the 2-needle approach. After inserting the first needle and obtaining the amniotic fluid, we then insert indigo carmine into the first sac. Methylene blue is not used, just for risk of methylmoglobinulemia, small bowel atresia. In those that chose not to do an injection of the indigo carmine, the first, there can be a misdiagnosis in upwards of 3.5%. The single needle approach may be considered for less maternal discomfort. The needle in the first sac is then advanced into the second. Of course, the concern in this situation is that there's the potential mixing of fluid or shearing the membrane. Sac placement may be a hindrance, and there's just small data in this approach. So probably the majority of us will do the 2-needle approach. For monochorionic twins, it is, in some cases, considered acceptable to test just one, although they are almost always identical, as we've said multiple times. So particularly if you have discordant anomalies or growth, then it might be important, or oftentimes we would consider checking for doing an amnio for both. And again, careful mapping, even in this situation, is important. Clearly, if there's different genders, it's a little bit easier, but in the situation where there are not, or there's not something major that we can obviously tell, the mapping is going to be important to ensure if a selective termination is going to be done, that you choose the proper fetus. So what about data on the risks for amniocentesis in twins? Well, there's 2 papers that look at a review of several studies. The first reviews 18 studies. Their overall loss rate was about 3%. And if done prior to 20 weeks, their loss rate was about 2.2%. And of these, 4 studies actually had a control group. 2.6 was the loss rate in the group that had the amniocentesis, compared to 1.5 in the group that did not undergo a procedure, with a relative risk of 1.8. The problem, as stated in the next sort of review, is that there really is no clear consensus on definition of loss, and particularly, say, when timing around the procedure. But the pooled loss rate, similar to what was shown in the other study, may be, and this is delivery prior to 24 weeks, or loss, I should say, about 3.5%. Again, very similar to sort of the background loss rate, or delivery prior to 24 weeks. So the general consensus is that we would expect the risk of an amniocentesis in twins to be higher than that of a singleton, but again, that is with the background of a higher loss rate. And when you survey providers that In one study that did survey providers that do the procedure, only 50% actually said that they quoted a loss rate, and the majority of those actually quote a similar loss rate to to that of a singleton. So which one do you choose when your patient comes to you, if she should have a CVS or should she have an amniocentesis? Well, we do see that the CVS does have the advantage of an earlier diagnosis, and there are improved outcomes in patients who do opt to do a procedure earlier, whether that be a fetal reduction, and even in those who choose to do amniocentesis and may want to pursue selective termination, as Dr. Stone's going to talk about a little bit later, the earlier this is done, the better the outcome is. In patients who are opting to go fetal reduction prior to the procedure, we're going to talk a little bit more about this sort of if there's an increased risk of now having two procedures. And we've seen that when we were looking at the trends, we've seen this as well as Dr. Evans, that when you look at women who are choosing to undergo reduction over the past several years, more and more women are opting to do CVS prior to having the reduction done. Now, some of that may stem from, again, whether it's anxiety, a lot want to ensure that the fetus or fetuses that are remaining are genetically normal. And at Sinai, we looked at women who were undergoing CVS prior to the reduction, because that's often a question that would come up in consultation. Well, now you're going to perform two invasive procedures. Is my risk now going to be higher? And when we looked at these women, there was no increase, in risk in women who were undergoing CVS prior to the procedure. And if you look at those specifically who were finishing or remaining with a singleton, actually there was a decreased risk in those who went to CVS of only 2%. And we'll focus a little bit on this as well, particularly with those with the starting number of 2. When they reduced to 1, there was a major decrease in sort of the reduction of loss. So that kind of brings us into and shifting gears to the pregnancy reduction. So due to the complications of multiple gestations that we've talked about, a lot of women are referred or have the discussion, whether it be with their primary provider or with us, regarding fetal reduction. So ultrasound, particularly with respect to chorionicity, because that's really going to dictate what procedure can be offered to the patient, that's going to be really important, as has already been discussed. Consultation, typically with an MFM, just to review the mom's history, to review what the risks are with multiples, what the procedure is and the description of the risks, and to offer and discuss genetic screening. And of course, this is never an easy decision for patients. There's a lot of sort of mixed feelings about it. For some women, it wasn't supposed to happen to them. Was it that they put back too many embryos? They feel like a magnet for lightning. A lot of patients feel like they're always that one in whatever number, 1 in 1,000, 1 in 10,000. And it's very difficult for a lot of them to be happy about being pregnant until they're able to sort of get past the hump when it comes to making this decision. So we try to dissuade any feelings of guilt and remind them that the goal is for not just a healthy baby, but just a healthy pregnancy. And that they wouldn't have been pregnant, they may not have been pregnant if they hadn't undergone these procedures to begin with, to sort of relieve themselves of the guilt of having gone through the procedure. And a lot of times after hearing the reduction data and hearing that there may be no increased risk of doing genetic testing before doing the procedure, it usually makes them feel quite a bit better. So again, just some things to mention. There's a lot of numbers on the slide, but looking at risks with multiple gestations, particularly if you want to look at NICU admission, especially in triplets, quadruplets, but in twins, 25%, 75% in triplets. And you look at risk of CP just compared to singletons, 4 times as high in a twin pregnancy and maybe 17 times as high in a triplet. Risk of death by first year of age compared to singletons, 7 times in a twin and 20 times in triplet gestation. And not to forget mom. To me, mom's always number 1. Gestational hypertension, increased risk as we go up in order, diabetes, placental abruption, PPROM, the need for cesarean delivery, as well as postpartum hemorrhage, which isn't mentioned here. And this slide really Again, just sort of a lot of numbers, but if you look at the two sort of columns that are highlighted in pink, and you're looking at both maternal as well as infant death, as you go up in number, particularly as you get to higher order multiples, the increased risk of not just infant death, but really of maternal death compared to when a woman is pregnant with singletons, and even compared to twins in the higher order multiples. I just wanted to mention, we put this slide in here just because oftentimes we do hand the babies over to the pediatricians, and although we are aware of sort of their immediate or their sort of neonatal sort of hospital stay, we oftentimes may not get as much long-term follow-up. And when you look at, when they looked at patients and long-term neurologic abnormalities, and this is primarily including cerebral palsy, if you look at the numbers comparing twins to triplets and quadruplets, you can see, twins 3.5%, and that pretty much more than doubles when you go up to triplets, about 8.5%. So what does the procedure entail? Transabdominal ultrasound-guided procedure where we insert intrathoracic potassium chloride. It's approximately about 2 or 5 minutes once the needle is inserted. We leave the needle in situ for watching for asystole for approximately 1 minute. We do rescan about an hour later to ensure that there is not a return of the heartbeat, as well as to check the viability of the non-reduced fetus. And we bring them back in 2 weeks just to follow up with them. And the mean gestational age and procedure is about 11 weeks. When women are opting to not have testing beforehand, and about 12 weeks, a little over 12 weeks, when they do have the procedure, the CVS, excuse me. Basically, that's just waiting for genetic results to return. I'd probably say it might be a little bit longer now that the microarray is often added, because that does take a little bit more time. So if we look at the trends of women who are undergoing fetal reduction. This is comparing, again, the first 1,000 cases to the second 1,000 cases. We're seeing that more and more women are starting with sort of a little bit lower numbers. So you see a little bit higher in triplets, but we are seeing more women that are presenting to us with just a starting number of 2. So more twins that are presenting to us for fetal reduction. And the finishing number is pretty remarkable when you look at sort of these categories right here. So we are seeing more and more women, as kind of goes along with the starting number, who present to us who are opting for reduction to a singleton. So from 11% in the first 1,000 to 31% or 32% almost in the second 1,000. So why do we see some of these numbers? Well, there's a decrease in the number of embryos transferred, so we're seeing a lot less with respect to sort of the higher order multiples. But what goes along with that is that a lot of patients are presenting us that with a later day of transfer, and that's actually increasing the monochorionic component of triplets that we're seeing. There's an increased risk, increased in CVS in the second group, up to 43%. This was just in that study, but now we're looking at our data over the last few years, that's probably upwards of 90% or so are opting to have a CVS prior to the procedure. And just to mention with the monochorionic component, sort of if you're looking who we're seeing with monochorionic twins, but particularly the monochorionic triplets, when you combine these two in the latter 200 of the group, we're seeing upwards of 12.5% compared to 2.5% in the earlier sort of 100. And why this is important, particularly in triplets, especially for some women who are considering remaining pregnant with triplets, some of the risks that are associated with a dichorionic triamniotic versus a tri-tri, gestational age of delivery, more delivering at less than 30 weeks. Higher likelihood of a low birth weight. If you look at sort of the composite neonatal morbidity, RDS, IVH, neck, much higher in this dichorionic triamniotic group, as well as intrauterine fetal demise and neonatal demise compared to the tri-tri triplets. And this is also contributing, which I'll mention, to women who are opting or considering reduction to singleton. And this is just a slide taken from courtesy of Dr. Wapner, just looking at comparing patients who remain as unreduced triplets, comparing to those that have opted to reduce to twins, and just improvements or greater gestational age of delivery, just overall. 35 to 36 weeks compared to 32 weeks. So reduction to singleton, which is a little bit of a controversial topic. It's not particularly offered in a lot of institutions for multiple reasons. We do offer it at our institution and have a lot of women that come to us specifically for that. And over the last year, about 40% of our reductions were to a singleton. Part of this is just patients are very savvy and very aware of what the increased risks of twins are, whether it's the internet or a lot of friends or family members who have gone through a twin pregnancy and have had some complications. Maternal age, sometimes with the risks as women are older that come with a twin pregnancy, the women do not want to accept a higher risk to themselves. That presence of the monochorionic pair and the triplets, although women sometimes are prepared to continue as twins, don't necessarily want to take the increased risk that's associated with the monochorionic pair, like Manisha had talked about. In some cases, when they have other children, fetal number or how many they then have with this pregnancy becomes important. Single parents, there are women that come to us that are doing this on their own and may not have a lot of family support, and taking care of 2 or more is not something that they feel that they can do for many reasons. And in reduction to singleton, prenatal diagnosis in this group does become very important, as does that mapping that we've talked about. So again, I'm just going to mention the questions, and then when it comes to that part of the slides, we'll just bring up what you guys have answered. So overall risk of miscarriage after a multifetal pregnancy reduction is 13% is A, B is 4.7, C 2.1, or D 7. So that's our first question. The second question is going to be reduction from twins to a singleton. Does that, true or false, does that have the lowest rate among patients who are undergoing multifetal pregnancy reduction? And my third question, which I think I kind of gave you guys the answer already. CVS prior to reduction increases the risk, this is a true or false question, of spontaneous loss compared to patients not undergoing CVS prior to reduction. So I'll bring back, if any of you guys responded, we'll bring that back. So contemporary outcomes, again, looking at the last 1,000 patients who underwent reduction. The mean gestational age of delivery is about 36 weeks. And of course, this is going to be dependent on finishing number. So for those with singletons, approximately 38 weeks. With twins, about a little over 35, and triplets, 30. There is a decreased risk in preterm delivery in the reduction when you compare those who've reduced to a singleton versus twins. Okay, well, the overall loss rate is 4.7%. And when you looked at older data, the risk was as high as 7, but we have found that the risk in our and this is similar to the background loss rate of twins. And this is important when counseling women who have presented with what the background rate is and what the loss rate is with respect to having the procedure. And a fair portion of these are actually after 8 weeks. And the chance of loss, when we tried to break it down in increments from the timing of the procedure, 0.8% were within 4 weeks, 2% were between 4 and 8 weeks, and a little over 2% greater than 8 weeks. And that number is a little difficult because particularly depending on the finishing number, if a woman stayed with twins or with triplets, that loss rate may have been sort of similar to their background risk. So this is sort of the important slide here. This was the second question. So based on the starting number, the loss rate when reduced to a singleton was 2.1%, and this is the lowest loss rate overall. And when you look when starting with triplets or higher orders, that rate is about 5%. When finishing number, and this is when you combine, good, we got it right, whoever's answering. Finishing number, when finishing with 1, and this combines both the starting from 2 and 3, is a little over 3.5%. So the lowest loss rate, so when women come to us with twins, discussing the loss rate to a singleton is 2.1%.
So some of the considerations that's really important when patients come to us is chorionicity, as been previously mentioned. And because a lot of times patients don't patients don't come to us till later on in the pregnancy, it's really important that we have early documentation of chorionicity. And as Jim and Manisha have shown you, the ability to detect dichorionic and monochorionic twins can decrease over gestational age. So it's important when you put out your ultrasound reports that it's really, really specified what the chorionicity is. And what's very important is also identifying the correct fetus. And Lauren had mentioned mapping everything out. And I can't tell you how important that is, because we've had patients that have come to us where there really wasn't good mapping or description at the time of amniocentesis or CVS, and we've had to repeat the procedure at that time. I just had a patient, very, very interesting patient, just over the last few weeks that I've been dealing with. She came to us she was actually donor, 46-year-old with donor eggs, and wanted to undergo CVS. She did it at another institution, and fetus B came back as a trisomy 13. It was a very small sample in the CVS, but it came back trisomy 13, and twin A came back normal. They both had posterior placentas, and they both were the same genders, but nothing else was really described other than just saying twin A or twin B. When she came for me for a consultation, she was already about 14 weeks, I'd say, and for trisomy 13, I couldn't find any ultrasound abnormalities, which you would already probably expect at that gestational age. And I suggested to her, just to be sure, I said, look, twin B is above A, that's probably what it is, but I cannot be 100% sure, and I repeated the CVS on fetus B, and it came back normal. Actually, it came back with a couple of mosaic cells. So, it was just sort of a little bit of a nightmare what the situation was. I then repeated the CVS on both A and B, just making sure that I tested both of them correctly. And again, showed a couple of mosaic cells in fetus B, the one that was supposed to be trisomy 13, but the vast majority were normal. Then had to do an amniocentesis to see if it was confined placental mosaicism. This couple was leaving for their honeymoon, we kept on delaying the honeymoon, but we just got results back showing that the amniocentesis was completely normal in twin B. So had that not been repeated, we would have terminated a completely normal fetus. So I can't emphasize how important that is. Of course, if they're different genders, that's very helpful, but it's not, gender issues are not always 100%, but it is helpful. And as I'm trying to stress, if there's any uncertainty when you're doing these procedures, just repeat the CVS or amnio just to be absolutely certain. I want to go over some of our data. This was our original data on selective termination. There were 200 consecutive cases. The vast majority, 82%, were twins, about 16% were triplets, and 2% were quadruplets. And if you look here, about half of the indications for the selective termination were due to chromosomal abnormalities. Structural abnormalities occurred in 43%, and the rest were a variety of Mendelian disorders or other. The mean gestational age of the procedure was 19 weeks, median 19 and a half, but it ranged from anywhere from 12 weeks to 23 weeks and 6 days. At the time of that publication, we were using gestational age as a cutoff, so 24 weeks, but in New York State, the law is 24 weeks from the onset of pregnancy, so in actuality, we can go up until 26 weeks for selective termination. Overall, there was a 4% loss rate, but when you look over here, the vast majority of our patients, as I mentioned, were twins. The overall loss rate was 2.5%. In triplets, interestingly, it was 12.5%, and we didn't have any losses in quads. And again, of course, this takes into some account the background risk of miscarriage among twins as well as triplets. And the average gestational age of delivery was 36 weeks. So what's important is that when we counsel these patients who are having a selective termination at 20 weeks, they're still sort of acting like a twin gestation. Their mean gestational age of delivery is very similar to what it is if they had continued with twins. So they're not lowering their loss rate as they do like in a reduction procedure or very early selective termination to that of a singleton. So this gives you a sense of when the loss has occurred. So if you see in the category of patients who reduced from 2 to 1, this was the timing of the procedure, and this was gestational age of loss. So most of them, most of the losses occurred between 2 and 3.5 weeks post-procedure. So again, that takes into account some of the background risk of miscarriage. And similarly in the triplets, except for the one that occurred 3 days later, I think that was clearly procedure related, the rest occurred further out. So we put together our data since that time on our most recent data on selective termination, and this is a paper that's in progress. So when you look at our new data, rather than being an average gestational age delivery of average gestational age of procedure of 20 weeks, now in our new data, the average timing for selective termination is 14 weeks. And that's predominantly due to the much higher diagnosis based on CVS. 62% of those patients had CVS, and in the old data it was only 7%. Amniocentesis, again, was much lower in our recent data. It was much higher in the older data. Starting number was very similar, 74% versus 82%, although it was significantly different, but ending number was no difference. And gestational age of delivery in our new data was 38 weeks, which was significantly greater than in the old data. And loss less than 24 weeks was about the same. Interestingly, though, when we looked at our losses, we looked at the losses, there were 5 losses, and as you can see, almost all of them occurred later on. The loss rate in the 51 patients who underwent selective termination less than 14 weeks was only 1.9% versus 6.9% when it was performed at 14 weeks or greater. So I think this, again, makes an argument for using CVS for diagnostic testing in the multiple gestations. Just because if you have to do a selective termination, it seems that the outcome is better if you do the selective termination earlier. So I want to talk a bit about selective termination in monochorionic twins. So as Lauren had mentioned before, we're seeing an increase in monochorionic twins after IVF. Part of that may be due to mainly 5-day transfers, but also manipulation of zona pellucida. We're seeing actually with prolonged embryo culture about 1% monozygotic twinning after single embryo transfer with blastocysts. So as you can imagine, selective termination in monochorionic twins using our usual KCL technique is not possible due to the vascular connection. So if you do KCL, you're going to end up having a loss of the co-twin just due to the vascular anastomosis. Over the years, there have been various different techniques that have been tried: embolization, fetoscopic directed cord ligation with suture, laser coagulation. But I think most recently, the 2 most common techniques are bipolar cord coagulation and radiofrequency ablation. So I think we'll do the same thing that Lauren did. This is going to be the first question, and we'll get to the answer after. Compared to radiofrequency ablation for monodi twins, bipolar cautery has a higher risk of premature preterm rupture of the membranes. True or false? So as you put in your answers to that, I'll keep going. So the very first publication on radiofrequency ablation for TRAP was published in 2007. They had a series of 29 patients, and overall the survival for the pump twin was 92%, and overall survival was 86%. Average gestational age of delivery was about 35 weeks. Interestingly, in this early study, 2 women suffered thermal injuries at the site of the grounding pads. So I want to talk a little bit about what radiofrequency ablation is and some just general concepts. It's been used really since the 1980s for a variety of techniques. For cardiac conditions, it's been used to ablate accessory pathways. My husband's an interventional radiologist, so he uses it to ablate tumors in the liver. This on the top picture shows you the generator, and the bottom shows you the instrument that we tend to use. And what it involves is the specialized generator produces changes in alternating current at very high frequencies. So the electrical current alternates between the prongs of that needle that I just showed you. And as the tissue ions become agitated, it causes frictional heat in the immediate vicinity of the electrode. And the high temperatures that are generated cause tissue coagulation caused by denaturation of the proteins. So you can imagine these are the prongs. So when we first insert this device in, the prongs are not deployed. And then we open it up to a certain degree based on how big the fetus is, because you don't want to cause damage to remaining tissue. So it has to be open specifically for a certain amount, and again, that will depend on the size of the fetus and gestational age. And this is typically what we see at the end of the procedure, this kind of echogenic area here. This is just a picture of the procedure. So the way that we do it in our institution, we do it in the interventional radiology suite. It's done under IV sedation with ultrasound guidance. We prep the skin. We use bilateral grounding pads. We do this under local anesthesia, and we make a little small incision with a scalpel, and we use the special needle. It's inserted into the fetal abdomen just at or above the level of the cord insertion. Once we're at the location that we want, we deploy the prongs, and we use 60 watts of energy for about 60 seconds, and we incrementally increase that power until we see that it reaches either 120 watts or when the impedance drops. Then we'll put color flow on, and we see a cessation of flow within the cord. Interestingly, you will still see the heart beating, and it's sort of freaky looking, but you expect to see the heart continue beating for quite some time after. So the important thing is seeing complete cessation of blood flow within that umbilical cord. We then observe the patient for several hours and then repeat the ultrasound, just making sure that we don't see any heart activity in that terminated fetus. And we do follow up with fetal MRIs and MCA Dopplers, which I'll get into. So in terms of a review of the literature, this review by Rossi in 2009 looked at various techniques for umbilical cord occlusion for selective feticide. And they defined PPROM as procedure-related death if it occurred within 4 weeks. And intrauterine fetal demise, if it was procedure-related, it would be within 2 weeks. And late loss would be after 2 weeks. They had close to 350 cases. And indications were TRAP for the half of them, TTTS, severe malformations, and a small percentage were due to discordant growth. Gestational age of the procedure ranged from 18 to 24 weeks. And when we first started learning this procedure, we didn't do any before about 18 weeks. The failure rate was about 3%. The highest failure rate occurred with laser cord coagulation. And also bipolar cord coagulation in that series. PPROM occurred in about 22% of the cases, and that's a number that's fairly consistent over a number of studies. Interestingly, fetal demise of the remaining twin occurred in 15%. Close to 80% occurred within the first 2 weeks of the procedure. And what they found was that survival was better if the procedure was performed after 18 weeks. Average gestational delivery about 30 weeks. 7% of the survivors had some neonatal morbidity, and 4% had mortality, mainly which was due to PPROM. In this study, it wasn't possible to perform a meta-analysis because there were so many different procedure types, but it appeared that the survival rate was higher with RFA, 86%, and bipolar coagulation, 82%, compared to other techniques. The incidence of IUFD appeared lower with RFA, 6%, and bipolar cord coagulation as well. So what is better, RFA or bipolar? This was a study that was a retrospective review. They had 20 RFA patients and they matched them with 40 patients undergoing bipolar cord coagulation. Overall, they had very similar survival rates. Gestational age of delivery was 36 versus 39 weeks, but they did have a higher rate of PPROM in the bipolar group. So you want to show the answer? Let's see what people had predicted. So I think that was right. Yep, everybody got it right. Oh, what a brilliant crowd this is. Let's see. This was a study that was done by the folks in England. I never pronounce this name right, but I'll do my best. Paramasivim. Don't tell him or her that I can't pronounce that name. But this was published in the British Journal of OBGYN in 2010. And they had 35 monochorionic pregnancies undergoing selective reduction with RFA. So it was all RFA. And it was for various indications, TTS, TRAP, IUGR, anomalies. This is what their technique was. They had given the patients Indocin, 100 milligrams, and progesterone starting 3 days, for 3 days post-op. Again, they inserted the needle into the fetus at the level of the umbilical cord insertion, confirmed asystole, and they followed the survivors with MRIs of the fetal brain about every month. They had mainly twins, but a few triplets in there, and the average gestational age of the procedure was 17 weeks. But as you can see, their range of procedure went from 13 weeks to 27.5 weeks. They had 100% technical success rate, and they had about a 3% loss rate, only one loss within 2 weeks of the procedure, and the stillbirth rate was about 6%. Average gestational age of delivery was 36 weeks, and their PPROM was about 14%, average about 8 weeks post-procedure. So I found this really, really interesting, especially looking at the earlier gestational age at the time of the procedure. So I looked at the data here and looked at all those that were performed less than 18 weeks. And as you can see, in this series, there was only one loss that occurred. It was at 26 weeks, and it was a termination of pregnancy after an abnormal MRI. But other than that, they didn't have any losses in the earlier cases that were performed. This was another review that came out from Michael Bebbington. They compared RFA versus bipolar cord coagulation. They had 146 complicated monochorionic twins at CHOP, and these were the techniques that they used for bipolar versus RFA. Very similar technique to what we use. And they did not have any difference in the gestational age of the procedure. On their average was around 20 weeks as well. No difference in gestational age of delivery. They did find a statistically significant higher survival in the bipolar cord coagulation group, 85% versus 70%. And it was mainly due to intrauterine fetal deaths in the patients undergoing RFAs less than 28 weeks. It was 17% versus about 6%. And their incidence of PPROM, again, was higher in the bipolar coagulation group, 27% versus 14%. So in this series, why was survival with bipolar better? Well, there was no difference in the severity of the cases or the indication for the procedure or the rates of PPROM. But the difference really was attributed to the rate of IFD of the co-twin before 28 weeks. And I think maybe part of it is that you do have to wait some time to achieve complete cessation of blood flow when you do RFA ablation. There can also be spasm that occurs in the umbilical cord. So when there's spasm there, it looks like there's no flow, but there can be flow that will occur, and so it's incomplete coagulation, and I think that's what's responsible for some of those early IUFDs. But the study really didn't show one clear advantage of one technique over the other. And this study was published more recently. And this was the same group that I showed you before, the Paramavisam group out of England. And they initially, that first study I showed you had 35 cases. Well, now this was a study where they looked at 100 cases of RFA between 2000 and 2012. Again, this is their technique. They use indocin and the vaginal progesterone. And they do MCA Dopplers actually in 24 hours later, and MRIs starting at 22 to 24 weeks, and then every 4 weeks. This was their indication. So they had the greatest indication was due to fetal anomalies, which was a little bit different, and that may play a role into some of their outcomes. Their average gestational age of the procedure was about 18 weeks, again, a range of 12 to 27 weeks, and average time of birth was 35 weeks. So overall, their live birth rate was 78%. And 6% miscarriage rate. Of those that miscarried, 50% miscarried within the first 2 weeks of the procedure. And they had about a 12% loss of the co-twin. They had a 3% incidence of abnormal MRIs, and that's why it's so important to follow these patients with MRI. And here they looked at the live birth rate, and they divided up into gestational age, and this is a little bit different now from what you saw before. So when the procedure was done at 12 to 16 weeks, the live birth rate was about 69%. 16 to 20 weeks was 81%, and over 20 weeks, 85%. So I'm not quite sure where we stand now on doing it early versus later. Statistically, there wasn't any significant difference in survival less than 20 or greater than 20 weeks, but I think that's, of course, there's only 100 cases, so it's really sort of hard to say. 12% incidence of co-twin demise, and again, 3% incidence of abnormalities on the MRI. The median interval to delivery was 14 weeks. In cases of thermal injury to the co-twin, and the live birth rate was 78% in this series versus in the prior series 89%. So I think bottom line for RFA versus bipolar, higher survival rates with RFA or bipolar cord coagulation, it's not quite clear yet. I think we need more data to know. I think RFA is I don't know how many of you do these procedures, but I think technically it's certainly an easier procedure. It's a shorter procedure, but again, it does have risks associated with it. Both procedures should be followed up with MRI. You may decide to do bipolar if there's enough amniotic fluid for insertion of an operative sleeve and deployment of the device. Also, if you have mono twins, this gives you the ability to, after you do the selective termination, the bipolar, to cut the cord so that they don't have that continued risk of cord entanglement with mono twins. RFA might be better if you have oligo and anhydramnios, if you have smaller fetal tissue volume, or if the umbilical cord leading to the twin is extremely short. Some patients may be offered electively to reduce using one of these techniques, but have to be appropriately counseled. And as Lauren mentioned, we practice on the Upper East Side of Manhattan, where everybody wants a perfect child. And sometimes when you counsel them about the risk of monochorionic twins, they are considered doing elective, usually RFA of one twin. But we do counsel them extensively about the risks involved. I think most important throughout these is that for twins there are various options that are available. How many is right have to be considered, options for CVS, options for reduction, selective termination, and RFA versus bipolar. So at least these patients who have complicated pregnancies do have some good options available to them. And that's it. And thank you so much for your attention remaining this late for our course.